This is scleral meticulous closure of scleral wounds. In fact, the clinical scenarios when we suture the sclera is zone 2 or zone 3 open glove injuries, which can be occult or manifest with or without IOFB, and endophthalmitis can complicate the situation. So I am just going to touch upon the main principles in the scleral suturing. The goals of the treatment, suturing, is to restoration of the integrity of the globe and avoidance of further injury to the ocular tissues. And very small scleral wounds, like a puncture wound by a sharp thin wire without uveal prolapse, can be managed conservatively with appropriate antibiotic therapy without suturing. But usually, most of the scleral wounds are sutured. And occult scleral rupture is a specific entity where you need a high index of suspicion. You will have a lot of clinical signs like hypotony, massive intraocular bleed, massive subconjunctival hemorrhage, and all these cases, globe exploration under general anesthesia is required. I am not going to touch occult scleral rupture, and special attention is given to the areas of muscle insertions, because many times in occult scleral rupture, the muscle insertion may be the area that is having rupture. Now there are some pearls. Always the scleral wound is closed from anterior to posterior, from the limbus back. If the limbus is involved, then without doubt that this first suture should be at the limbus, like Dr. Vinay said. Otherwise, if the limbus is not involved, start from a recognizable landmark like the apex of a laceration, triangular area. The apex has to be, usually it is non-absorbable 8090 nylon, silk or dacron with a spatulated needles. Even though small scleral ties, we do use vicryl also. So the suture has to pass deep through the sclera, avoiding damage to the underlying choroid, and clear the wound from conjunctiva and tenons. That is extremely important. So this is the first suture. Like Vinay said, the holding of the this thing is not very good. That is why the difficulty in approximating. This is the limbus is approximated first, and equidistant, deep enough, and then you have to explore back. So this wound is extending. Sorry. Yeah. Then next bite is taken. Interrupted sutures are taken. Deep bite is taken. You should never excise uveal tissue in the zone 2 or zone 3. If there is vitreous, that can be trimmed. Reposit the retinal tissue if it is incarcerated. Interrupted sutures. Clear the area. Now, the large wounds extending posteriorly, it is better to employ what is called close as you go. You suture this area, then open, suture the next area, then open, close that area, then open next area, like that. Otherwise, if you open the whole area, the intraocular contents may get protruded out. So that the initial bite, you can keep it long. So that can be used as a traction suture. So you can pull the eyeball little towards this side without exerting pressure, so you see the other area clearly. So that can be used as a traction suture. Open part of the laceration is supported by the periorbita, and this will prevent intraocular contents from prolapsing out. That is why this is called close as you go. So initially you approximate the limbus. If the limbus is not involved, approximate the triangular apex here and here, then suture like that and go as you open. So this is the classic picture from Pierre Ami's textbook. This after you put 2 or 3 sutures, you open and go explore posteriorly and keep going. Put another bite here, then again open. Sometimes, usually this is almost always taken under general anesthesia, because you don't know how much back it may be extending. So you have reached the end. Then you can finish, explore that it is not going beyond that. You can stop at that. So many times if the wound is extending too much posteriorly, you may not be able to find the posterior extent. You may have to leave the posterior extent little without suturing, because if the zone 3 wound sometimes can extend very posteriorly. But as much as possible, suture the whole wound so that. So prolapsed uveal tissue is generally reposited. If the vitreous is present, it is amputated. Prolapsed retinal tissue is reposited. So this is a principle. Unlike a uveal tissue in corneal penetrating injury, which is upsized. If the scleral wound extends under the insertion of the rectus muscle, disinsertion of the muscle is mandatory, usually required. And if the wound is extending posterior, too much posterior, we can leave the posterior end sometimes. This is a bad case, 360, it's occult scleral rupture. It is opening 360 degree peritomy, but you don't do the whole area. We know that it is the upper part. Open this area, put a traction suture and start suturing from this side, one end. You have to keep suturing. Then this is why it is not. Muscle has to be, there is some problem in the video. Right? Muscle has to be disinserted in many cases. You can directly play like that. Yeah. Yeah. This is. So if the scleral defects cannot be closed primarily, especially in the setting of scleral thinning, graft material may be used. Homogeneous sclera is usually used for large defects. There are some other materials also which can be used. This is a graft. This area is very thin and it is again leaking. So this is a graft placed with glue. That graft is placed. And graft can be then trimmed and cut. This is usually done if there is a lot of tissue loss from the sclera. So any frankly necrotic or infected appearing tissue has to be removed, and devitalized tissue has to be removed. And this, since it is mentioned, sclerotomy suture nowadays everyone is using 23 gauge or 25 gauge. Sclerotomy suture is not done. This was the old time 20 gauge. This thing we put a X sort of shoelace or X suture. This is, since it is mentioned in the talk, showing this using a vehicle, 70 vehicle. Thank you for the kind attention.